Wonderful. Thanks so much, Valerie. Good morning, good afternoon, good evening to all of you joining across the world today. My name is Cicely Thomas. I lead the health financing team at the Global Financing Facility for Women, Children, and Adolescents, the GFF at the World Bank. And we're really thrilled to have so many of you on the line. It's an honor to be with you and to introduce this exciting and informative webinar. This series of webinars is organized by the WHO and the GFF World Bank as part of a collaboration and learning program that supports health system strengthening for improved health outcomes through promoting more sustainable and equitable health financing for primary healthcare services in low and middle income countries. And as part of this collaboration, we've supported workshops that bring together ministries of health and finance, representatives from subnational levels of the health system, as well as partners to understand country needs and reforms and to consider and apply some of the good practices around PHC financing in these contexts. So to inform the focus and the content of this webinar series, and also in the spirit of learning and collaboration, we conducted a survey across countries to understand the interests, the demands, and needs around primary healthcare financing. And several weeks ago, colleagues hosted a version of this webinar in French. And today we're presenting here in English with bringing you some new country perspectives. So we have with us today global experts who will share with us good practices and innovations in primary healthcare financing, as well as regional and country experts who have the frontline experience of working on these reforms to ensure that this rich country experience is shared more broadly with those of you on the line. So the webinar is really an opportunity for understanding how countries are putting some of these good practices into place. And it's a space for you as this broader community, country policy and decision makers, global partners, and others to share and exchange on these topics. It's an opportunity not only to share some of the challenges you're experiencing and that have been experienced in PHC financing reforms, but also what's working and some of the nuts and bolts of how this is working in different countries. So it's really an effort to combine the global and the local and regional expertise. So we hope that there'll be very active participation from all of you. This will be more fruitful if you share your views and your questions and really help ensure a constructive dialogue. So do please follow the instructions that Valerie gave us at the beginning of the webinar. Now, today we're focusing on health facility financial autonomy, and we'll review arguments for and against greater financial autonomy of primary healthcare facilities, some of the obstacles to the appropriate public financial reforms, and some possible ways to overcome these obstacles. And I'll introduce our esteemed panel. Next slide, please. First, we'll hear from Sophie Witter, a health economist specializing in health financing policy and health systems research in low and middle income countries. She's a professor in the Institute for Global Health and Development of the Queen Margaret University in Edinburgh and a co-director of the Rebuild for Resilience Consortium. For the past decade, she's focused on fragile and conflict-affected settings. We also have with us today, and just want to make sure our slides are advancing here, that you all can see our panelist slide. Danielle Cerebro, who's a program manager at CABRI, the Collaborative Africa Budget Reform Initiative, and a research associate at ODI Global. She works to ensure that public financial management contributes to better service delivery and developmental outcomes. She holds an undergraduate degree in politics, philosophy, and economics, and her postgraduate qualifications include honors and master's degrees in economic development and a postgraduate diploma in health economics. We also have with us Richard Kabagambe, who's an economist with over 20 years experience in health financing, education, planning, monitoring, and evaluation. His background includes the Uganda Health System Strengthening Initiatives, public financial management reforms, planning and budgeting in health sector, and national health accounts work. Richard holds a Bachelor of Science, a Master of Science, and a Master of Arts in economic policy and planning. And finally, last but not least, we will have Hélène Barrois, who's a senior public finance expert at WHO in Geneva. She specializes in budgeting, public financial management and budgetary space for health issues. And she has a bachelor's degree in public finance and economics from Sciences Po, a master's in public health from the London School of Hygiene and Tropical Medicine, and a PhD in health economics from CERDI. So please, we'll move to our first panelist now, and Sophie's slides will focus on really giving us some of the definition around this financial autonomy agenda. So over to you, please, Sophie.
Thank you very much, Cicely. Good day, everybody. So I'm going to be discussing some work that was commissioned by World Health Organization last year. I think we can go straight on to the next slide. I'm going to be giving some, thank you, some, as Cicely said, some definitions, but also some discussion around why we think this topic is important, and a couple of tools that we, and sort of frameworks that we developed as part of the work. So what do we mean, first of all, when we talk about provider autonomy? So generally speaking, and this does come down to a fairly common sense concept, I think most people get pretty quickly, which is around the ability of health providers to exert influence and control over the delivery of services. So it's a transfer of decision rights to facility managers, and it's obviously not just relevant at the facility level. There's also an interesting conversation to be had around how districts work, for example, the higher levels of the system. But for today, we're focusing on the provider level. And so clearly there are different aspects that can come into this. This can be around how you manage your staffing. It can be around how you manage infrastructure and equipment, also clinical decision-making and service organization. But the financial management is the aspect we want to discuss today. So particularly thinking about allocation and spending of funds. And clearly these different elements of autonomy can go together or can be separate. So some in different settings, people have control over one element like staffing, may not have control over finance or vice versa. So they interconnect, but they're distinct. Next slide, please. So what do we mean about financial autonomy specifically? So I think this definition by Barassa and colleagues is a good one. It refers to the level of control and influence that health facility managers have to mobilize, allocate, and spend financial resources. So in that definition, you can see that they're using a kind of budget cycle structure, and indeed that's one we also used when we thought about the typology. So just to make an important point up front, which is that autonomy is clearly, when you start to think about it, not a binary issue. So it's not that you have autonomy or you don't. It's about what degree you have in relation to what. And I think as we discuss it also at the country level, this will come out that it's about having the right amount of autonomy for the context you're in and the kind of functions you're carrying out. So it's about the appropriate level for your setting. Next slide, please. So just to highlight some of the reasons why we think this is relevant, it's not a new topic, but it's particularly relevant in relation to a lot of different kinds of reforms that have been in discussion and in play recently. In particular, areas like strategic purchasing essentially rely on an assumption that providers can respond, that they have some ability to adapt and make decisions around resource use. And equally, a lot of the provider payment reforms either require autonomy or change it, so themselves directly influence the amount of control that providers have over resource management. Reforms like results-based financing, again, provider autonomy is a clear plank in that, as it is also for the direct facility financing modalities. And then we're also very interested in how financial autonomy interacts with the public financial management sphere, because there can be synergies, but also tensions there. And another one we highlight, and which I think speakers highlight, is around decentralization. A lot of countries have been undergoing decentralization reforms, and there can be a very strong effect of either enabling increasing autonomy at specific levels or indeed reducing it. And that's been part of the conversation around the literature there. And I think lastly, just to highlight that the whole COVID pandemic really brought this question to the fore, because when shocks happen and you get rapid change, the extent to which providers are able to respond becomes really crucial. So next slide, please. So in the light of all of that, we were engaged in doing a report last year for WHO, and it was focused specifically on the primary level. And the reason for that is that that has been quite neglected. And indeed, when we started to look at the literature, because it started as a kind of scoping review, we found that there are almost no studies that looked specifically at financial autonomy at primary care level. So there's a literature, obviously quite substantial literature around hospitals, but evidently people haven't thought that primary care had enough resources to manage, or for whatever reason, it's been very neglected. So we looked at how as I said, how it's conceptualized, also what kind of reforms have triggered it, which I've just been discussing a little bit, but also how much financial autonomy do providers actually have? What are the key design and implementation issues here? So you can see a long list of questions on this slide. What are the impacts of financial autonomy, both positive and negative? So taking a sort of neutral stance on whether, if you like, it's a good thing. What are the prerequisites for it? So what is it affected by in terms of the wider system issues? And what lessons do we draw from all of that in terms of what the kind of right levels are for different settings? So the methods we use for that, although we did start with the literature was actually not that informative. So we ended up using very sort of mixed set of methods, which included also looking at some of the data that WHO holds from its health financing progress matrix, which has at least one or two questions very specifically on this topic. We also did some very rich interviews with experts and draw on our own expertise, but we also had a conversation after the Montreux meeting where the first findings were presented, and enriched our sort of analysis after that discussion. Next slide. So I'm not going to go through all the findings of that report. Obviously, today we want to prioritize interaction with all of you, but just to say that first of all, in terms of the actual level of autonomy that primary providers have from the relatively few data sets that are on this, and you can see this is work done by Cara Hansen and colleagues on primary healthcare. The first point to make is that the level of financial autonomy is relatively low, so it's around a third or just less than a third of facilities reporting that they have the ability to manage and retain money, for example, or retain funds across years. And you can see from the graph on the right that there's a little bit of a gradient in relation to the kind of economic level of the country, but it's not actually a very big difference. So it's still quite low, even in the upper middle income countries. Next slide. So based on these different methods that I outlined, we developed a kind of conceptual framework that looked at, firstly, in the center, kind of what are the attributes or the aspects of financial autonomy that matter. And you can see that we've used in the light blue box in the middle a kind of budget cycle structure. So looking at planning, fund mobilization, managing funds, sort of expenditure controls and reporting. But we were interested in what came out as kind of key contextual factors that influence that. And so you see on the left-hand side a sort of summary of some of those. And I think none of them should be massively surprising, but it is useful to kind of put it all together in one place and kind of look overall at the issues. So public financial management and legal frameworks are clearly very important, will often put constraints around use of locally generated funds, for example. Equally, provider payment mechanisms are very important too, in that some of them inherently give more control over resource management, like capitation and case-based payments compared with others, like line item budgeting and so on. Equally, the budget structures are important, how different kind of strands are managed, and the status of providers within the PFM system is really important to look at, because all of these systems are very mixed and you find different levels of autonomy depending on multiple types of status of providers. The numbers of funding stream is really a crucial aspect to think about as well, because each of those will come with different constraints, and as we know, many providers are managing and juggling very complex different sets of payments and resources, each with different constraints. And then more broadly, what are the ongoing sort of broader political administrative reforms, and how much willingness, and this is really more of a sort of political economy question, but how much willingness is there to give more power to the lower levels of the system? So those are some of the, and then I'm sure it's not exclusive, there'll be other things as well, but some of the key contextual factors that we brought out. But then thinking more specifically about prerequisites. So if you have autonomy, in what context is it likely to lead to good outcomes? And so the sort of middle column tries to, I've got lots of middle columns, haven't I? But anyway, second to the left column tries to bring out some of those aspects. And again, some of them are fairly obvious, but still important to highlight. So, for example, sufficient, predictable, and timely funding. Well, clearly, if you have lots of financial autonomy, but you don't have any money, that's not really going to be a great arrangement. Staff time and skills are important, but also this issue of willingness to sort of exert leadership, which is one of those very sort of soft skills, very intangible, but very important. You know, is there a willingness to kind of take on that responsibility and use it actively? And you find that in some systems, in other systems, it's very problematic. Is there clear guidance on tools for planning, budgeting, and monitoring? This is really important because some of these aspects can be very intimidating, especially if you're looking at a small team in a primary provider. If systems are very complex, very onerous, very frightening in terms of potential sanctions if you do things wrong, then your willingness to exert and use any kind of autonomy actively is going to be reduced. Is there an alignment with the PFM system? Often we find there are clashes. You have reforms which try and give more financial autonomy. Meanwhile, the PFM system is actually exerting a lot of control for risk reduction reasons and so on. And I think others on the panel will talk about that a bit more. Have we got, have we simplified the rules of public financial management so to make, as I said, the process more for the primary care providers, which are small teams, more manageable? Do we have functional and proportionate oversight and accountability? So an appropriate level, but again, not one which is too off-putting to managers. And are the resources in terms of practical things like ICT systems, ability to, procure medicines, etc., are those actually available in your local area? Because again, that's not a given everywhere. So you can see that there's a lot of contextual factors that influence it. There's also a lot of prerequisites, which already will tell us that this is not going to be a simple story. It's not always going to work better. But then looking to the kind of right-hand side of the figure, what are the outcomes that it could lead to? And the ones in dark blue are the kind of positive ones, and the ones in orange are the sort of more the risks. In fact, the literature doesn't give us enough richness at this stage to establish the degree or the extent of many of these. So these are kind of hypothetical, really. So more flexible use of resources and innovative strategies, of course, in a way that's part of the core theory of change of financial autonomy, but potentially also increased availability of commodities if you have funds, that you can top up supplies locally, etc. Better management planning, increased motivation of staff, because we know that staff are really affected by working conditions. So if you're able to improve working conditions in terms of, fixing things, maintaining things, etc., then that's going to be positive. Potentially can also engage positively with community participation over the management of resources and the use and priority setting of those, and reduced waste because you're able to define more appropriately what you need locally. So those are all some of the there's some evidence of those in the literature, but as I said, it's still quite thin and it needs a lot more work. So for the researchers out there, please chip in where we've missed something, but also pick up on some of these areas which do need more work. On the negative side, there's obviously a risk, especially on the revenue raising side, of extractive practices if facilities have incentives to increase patient charges. And again, there's some evidence of that, but fairly limited. Increased workload is an issue because we are asking facility staff to take on more, management and accounting and so on. Low quality of drugs if the procurement mechanisms locally are not done well, and obviously a concern about a disconnect between national policy and local practice. Although again, I don't think we found much evidence of those, and equally fiduciary risk. So many of those are quite theoretical, and there's not that much evidence. But potentially you can see that ultimately, if it works well, you've got the ability to improve facility performance and indeed resilience. So this issue of adaptability to shocks is really an important aspect too. Next slide. Okay, this is my final slide. Just to say that another tool that we developed in this work was a kind of typology. This is not a normative typology, it's a sort of descriptive one saying what are the common scenarios that you find at the primary facility level. And we've structured it by the budget cycle. And you have a kind of low, medium, high financial autonomy scenario. Just to highlight that it's not always the case that it's going to be better to have a higher level of financial autonomy. It really does depend on your situation, the job you're doing, the circumstances you find yourself in. But at the same time, I think when you look at the low financial autonomy scenario, it doesn't look particularly attractive. So probably in most contexts where you would want to be finding yourself in the sort of medium to high. But again, I welcome Richard and others' reaction on the panel, and people say where they see themselves sitting and whether this makes any sense. But just to highlight some of the aspects, so in terms of mobilizing funds in a low autonomy scenario, typically your funds would be fixed externally, so you're not able to mobilize additional funds. Funds get sent up to Treasury commonly, so you don't retain them, and you can't roll any over between financial years. Whereas when you move to the sort of medium and higher levels, so medium one, you might have some fixed, but you have some marginal ability to generate funds and keep them. And you may have some strands of your income that have a bit more flexibility. Whereas at the high level, you're able to kind of raise funds independently from multiple sources and retain them, including across years. In the planning domain, typically in a low financial autonomy scenario, you would be allocated from above. You're not really influencing your budgets. Whereas in the medium scenario, you're making some input, you're able to influence it, although you don't have overall control. And finally, at the top level, you set your own budgets, you structure your own budgets. Again, which of these are most important in different settings, I think we can discuss. In terms of the management of funds, so in the low financial autonomy scenario, budgets are fixed, so it's very hard to change across different budget lines, so expenditure is often ring-fenced, and there are very sort of strict rules about how you can use different funding sources. Whereas in the medium scenario, you can make some changes in year with higher authorization, so there's some flexibility. And in the high autonomy scenario, you're able to shift with clear, within parameters, shift funds across budget lines, so more flexibly. Just then on expenditure, this kind of picture is that at the low autonomy scenario, you're essentially not spending. The expenditure is being made at a higher level on your behalf. You're often getting items in kind, and so you don't have bank accounts. Whereas in the medium scenario, you have access to some limited funds. Often these are for sort of small operational costs. You may have bank accounts, you may have some access to petty cash. And in the high autonomy scenario, you can actively manage your major expenditure streams, and that can go all the way through from staffing, medicine, supplies, and so on. And in that scenario, you would usually have all primary facilities with bank accounts. Finally, reporting, which is the kind of corollary. It's your accountability for your autonomy. And so in a low financial autonomy scenario, you often are not recognized within the system as a primary provider, and therefore you're not having to provide reporting. Whereas in the medium one, you may be reporting, but via a higher level unit like the district. And finally, at the high level, you would be expected to account within the public financial management system. You are a recognized accounting unit. So these are, it's a typology. It's obviously what you will find is different levels of autonomy across the domain. Some may have high autonomy in some aspects and not in others. Again, interested to hear whether this is useful and helps us guide our thinking about, are we in the right place for our context, and what do we need to change? What are the reforms we need to bring in? So back to you, Cicely. I hope I wasn't too long there.
Thanks so much, Sophie. Perfect timing. So thanks to Sophie for really sharing with us the state of where we are with financial autonomy globally and why this is so relevant for many of the reforms that we're all engaged in, and then really describing some of these contextual factors, prerequisites, and some of the positive and negative effects, and then sharing with us this typology. So let's go now to our two panelists, Danielle and Richard. Danielle will speak to us about an experience with a cross-country policy dialogue on public financial management as an enabler of financial autonomy. And then we'll hear from Richard sharing with us the experience in Uganda. And just to encourage you to please still enter your questions into the Q&A. We see some coming in and look forward to speaking about those shortly. Over to you, Danielle.
Great, thanks so much, Cicely. Hi, everyone. So I'll be sharing some lessons from, as Cicely said, a policy dialogue that we ran at the Collaborative Africa Budget Reform Initiative. And you can go to the next slide so I can tell everyone what the Collaborative Africa Budget Reform Initiative is. Essentially, we're an intergovernmental organization that provides a platform for peer learning and exchange and capacity building for African finance ministries and select line ministries. We've primarily focused on the health sector and will probably continue to doing so. But yeah, we work across Africa. We have 17 member countries, and we hope to get more. You can go to the next slide. Thank you. So we held a policy dialogue in Mauritius earlier this year, and that was with 13 African ministries of finance, health, and also selected local government representatives. My two co-panelists, Richard and Sophie, are somewhere in this photo. But this dialogue essentially provided a platform for trying to improve and reach a shared and common understanding between health and finance officials of essentially what facility autonomy is, what direct financing is, and the potential advantages and risks. And we highlighted how the PFM system and the Ministry of Finance can better support facility autonomy, and in that way sort of created a basis for continued dialogue and collaboration between these three sets of stakeholders going forward. We can go to the next slide where I'll present some of the lessons that we learned from this policy dialogue. So the first one was, and I guess this was a hypothesis going into the policy dialogue, and it was why we decided to run it, but was very much confirmed at the event, and that's that finance ministries seem to be very unfamiliar with the potential benefits of increasing autonomy and aren't really thinking about the bigger picture of health outcomes and improved efficiency and effectiveness, and how they can enable this reform and how they are currently a bottleneck to it. And health ministries and their partners and allies tend to view the PFM system as this bottleneck to increasing autonomy, but there's very little understanding of why or how or what needs to be adjusted. And I think what was very clear is that finance ministries have a much bigger role to play in sensitizing health ministries and health stakeholders on how existing PFM arrangements work and how they can and can't be adjusted and what's feasible and practical in increasing direct financing to facilities and the consequent autonomy. But yeah, health ministries also have a very important role to play in actually convincing finance ministries why they should support greater autonomy and make adjustments to the PFM system. I was quite pleasantly surprised at the event at how open ministries of finance seem to be to this reform, at least in principle. But it was also quite clear from a number of delegates that they do need a bit more convincing, and that what they really want to see is that this reform will bring about value for money. Sophie's already mentioned that there's limited evidence of the impact of autonomy at the PHC level. And that's what we need to start developing so that we can make this case more strongly. We've so far relied on evidence from high levels of care. But yeah, the Ministry of Finance just needs to see more evidence that increasing and adjusting the PFM flexibility is commensurate with the potential benefits of increased cost effectiveness and better service delivery. And then my third key takeaway was that another aspect of selling this reform to the finance ministry is illustrating that facility managers actually can manage and account for the financial resources that they receive. Most of you will probably know that facility managers are often clinicians. They don't have much financial management background and may struggle initially to effectively manage and account for resources. So it really is very crucial, and this is, I think, a Ministry of Finance and a Ministry of Health role, for them to receive adequate training and support. There's other countries that presented at the event which discussed how, that small facilities in their country, which are often headed just by a nurse, can be assisted by a local authority officer or accountants from larger facilities. Richard, who will be chatting to us now from Uganda, In his country, Uganda, dispensaries are actually supported by the sub-county accountant. But either way, we facility managers are going to take on more of an accounting officer responsibility and more financial management responsibility. It's essential that the PFM regulations that they need to abide by are very simple, that they well-defined and they clearly communicated. Otherwise, you really do risk overburdening a clinician and a manager whose primary task is to actually deliver health services, and that's their mandate rather than financial management. And then the last key message on this page, and again, it relates to not overburdening these facility managers and also reassuring the Ministry of Finance, is that a very pragmatic way to go about this is to increase responsibility gradually, and that's through quite carefully sequencing the cost categories under facilities control. And this was presented at the policy dialogue by Sheila O'Doherty, who's been a panelist in many of these sorts of webinars. And she emphasized the importance of not throwing the entire budget at facilities on day one, but rather allowing facilities control over much smaller sums of money initially, and then allowing that to support their learning and their financial management capacity more gradually, and also providing that reassurance that they can eventually manage larger sums of money that would be associated with more fiduciary risk. And on this, and I think it actually was in Sophie's slide, one of the most basic starting points is to increase facility autonomy over some operational expenditure and maybe purchasing some drugs, but that in the beginning stages, you wouldn't want to devolve responsibility even for salaries. Maybe, you can do some contract workers and some performance bonuses, but not the entire HR component. It often results in inequities if it's done too quickly across facilities, and you probably never want to devolve full responsibility for large capital investments. Okay, thank you, Bruno. We can go to the next slide. Great, thank you. And then I have 3 more messages, and I think I should be in time. And this one is about spending controls. And as I said, in the initial stages of increasing autonomy, we're talking about like quite small sums of money just for operational expenses. And most primary healthcare facilities don't actually need huge amounts of money. Often just $500 a month can be enough to cover their sort of basic operational costs. So because of this, it's very important that the Ministry of Finance pragmatically balances, and that's why I've got to scale accountability with efficiency. And this was something, again, at the policy dialogue that Cicily's colleague at the World Bank, Marit Piatti from Kirschen, reiterated that these very small sums of money aren't going to ever really pose a major fiduciary or financial risk or threaten sort of a country's entire fiscal discipline. And so they may not need to be subject to the sort of the rigid ex-ante spending controls that other bigger items of spending are. And we want more accountability, but that's not also necessarily always facilitated by more spending controls. And excessive controls can often actually just force people outside of the system. I mean, if you've got to procure very quickly in an emergency and you just can't do that, people are going to go outside of the system, and which ends up undermining accountability. And then the second message on this slide, and something that's very close to my heart, is that how any of these reforms are approached needs to be driven by an understanding of the problem it aims to resolve and the specific context in which it's being introduced. And I say it's close to my heart because at CABRI, we have an approach called the problem-driven iterative adaptation approach, where we ask teams of officials to really diagnose and dissect problems before they even start considering any small action steps. But yeah, at least how I see it is that what matters is not that direct financing or increasing autonomy is introduced, but rather whether it actually attenuates bottlenecks in delivering health services. And I mean, at this event, the benefits of increasing autonomy and getting funds directly into the hands of facilities was made very apparent. But it also was useful in our discussions to be reminded by quite a few people that this may not be a priority or feasible in all contexts. In some cases, I think some people might shoot me for saying this, it might be more pragmatic for a district health office to continue holding financial resources, at least in the interim. And this might be true when facilities resources are already allocated quite equitably and distributed reliably, or there's only a small number of facilities under a district health officer's jurisdiction, or a facility in charge, a nurse, just has no capacity at the moment. But we've seen this as a spectrum that can develop. Yeah, so then the final like takeaway for me at this event was go in understanding how digital public financial management tools can support health financing. This is work that we're focusing on. As Cicely mentioned, I also work for another organization called ODI Global, and we're doing quite a bit of work in understanding what sort of systems facilities are using and how effective these are in serving their purposes. But at the event, many facilities, particularly those in Anglophone countries, were reported to still be using paper-based forms and do that for their financial reporting with very little or no consolidation. In the Francophone countries, actually, it was more common for facilities to have access to the centrally designed integrated financial system. But that also has presented challenges for facilities, and this is part of the work that we're doing at ODI, that this is sort of this limited infrastructure at more rural levels and interconnectivity, and maybe even more fundamentally, the fact that the system designed centrally often doesn't suit or work for the needs of a facility manager, means that this is a solution to just use a central system. And then one positive example that probably a lot of you already know of that we heard about at the dialogue is Tanzania's Facility Financial Accounting and Reporting System, or FARS. And that's a web-based and mobile application that's actually interoperable with the central and local government financial management information systems. And I think that's probably where we want to head, these sort of interoperable systems, and ensuring that data governance allows for these systems to speak to each other. But progress is quite slow, and I think, yeah, a lot more evidence is needed on what countries are actually doing and what facilities need, and yeah, how we can support that. But that's me done. Thanks, Cicely.
Danielle, thanks so much for that, and really helpful to hear some of the outputs from that dialogue with both ministers of health and ministers of finance, and thinking about the sharing of information or perspectives from those two groups in terms of the PFM rules and why they're important, but also convincing Ministry of Finance why it's important for this greater autonomy. I think you touched on several of the questions that are coming up here. So maybe we'll come back to you around some of these issues of how do you increase leadership and build capacity at the facility level, but also this question around the digital tools. So thanks very much for bringing those up. Richard, it's over to you now for this experience from Uganda, please.
Okay, thank you very much, and good afternoon, colleagues. I'm delighted to share Uganda's experience in this presentation regarding the reform of financial autonomy in our health facilities. And I'll take some few minutes on the outline of this presentation. We shall look at the purpose of the reforms, preface, and some of the reforms that have helped implementation of the financial autonomy. I will also dwell a bit in the key enablers that has helped Uganda to reach where it is. And then we shall also review the autonomy across the budget cycle and try to rank, to give ourselves ranks where we are, and then maybe some few lessons as we conclude. Now, as you're aware, Uganda has also been streamlining most of the financing in order to achieve efficiency, but also improve service delivery. And one of the fundamentals of the Public Finance Management Amendment was done in 2015 that streamlined the government practices and supporting decentralization program. And in order to do this, the reforms aimed at improving resource allocation. We're also looking at adequacy, equity, and aggregate control, prioritization, accountability, and efficiency. And we had a lot of support from specifically the World Bank and other donors to implement these reforms. But for the purpose of this presentation and discussion this afternoon, we look at the key features of the reform that strengthen the intergovernmental physical transfers with direct transfer of funds to the facilities bank accounts. And also in this particular one, the World Bank gave us a very helping hand in implementing this reform. Now, let's look at some of the broader reform, PFM reforms that mattered that were very essential in the financial autonomy of the health facilities in Uganda. The first one, I think, let's look at the physical decentralization reform that was done in local government in order to strengthen the process of decentralization in Uganda by first and foremost making the local governments, these are the district, city councils, town clerk, to make them autonomy. And this autonomy in the local governments through decentralization paved the way to ensure that also the service units, these are the health facilities, get the financial autonomy that we are going to look at. Secondly, we had also an introduction of integrated financial management system in 2004. That's about 20 years ago, as a commitment to control system to ensure spending is within the approved budgets and work plans. This system was rolled over in 2004, but we started with the central governments. Later, it went into the local governments, and it is a very perfect system that makes sure that spending is within the work plans and within the approved budgets. The third one we had was also in 2013, that's the Treasury Single Account, and it helped us to make sure that there was easy monitoring of cash management, and there was also budget execution and absorption of resources. We need to understand that before the Treasury Single Account was implemented, so many central governments and local governments had so many bank accounts. So it would actually be seen one ministry would be running out of money while the other one has a lot of money. So, and it was not efficient at all. So the single treasury account puts all those accounts together, and there is a reconciliation every evening to know how much government has spent and how much money is on the account. So the treasury single account helped us a lot, and it helped also to monitor the absorption of these resources. Last year, we had also in the 2017-18 financial year, we introduced the program-based budgeting across the entire spectrum of the government, and this has improved efficiency, effectiveness, and equity in government spending. And there are so many other reforms that have come through, including the IPPS, that's the one which controls the payroll, result-based financing, and direct facility financing. So we have a lot, but these four major ones gave way to our financial autonomy in the health facilities. Next. Now, I wanted to take you through my own judgment of autonomy across the budget cycle. How are we doing at facility level? And this is based on the cycle of the budget we have in Uganda. And the first one is mobilizing funds. What we have now is operational funds are fixed. We have a fixed budget for operational funds depending on the facility. And these operation funds are based on a formula that we integrate into our system that caters for, that we look at parameters like population, infant mortality. So It is fixed, but varies from facility to facility, depending on the population. Hard to reach areas have a different parameter. Where in fact mortality is high, also where there is high levels of poverty, the parameters are different. But that is fixed, and we don't charge. There are no user fees in our facilities in the health centers. But we have also result-based financing, that those funds are tagged on performance measurements, and it is it's like now it's 4 years program that we have implemented it for about 4 years, but we have institutionalized it in the whole government primary care grant this financial year. And there is ability in these facilities to mobilize additional resources from donors or NGOs. But the funds are spent within a financial year following the PFM requirement. And I would, without hesitation, say that on that one, these facilities were not yet there, but we are in the middle rank. The scenario there should be gazetted as middle. So how are our facilities planning? In the planning, during planning, we give the indicative planning figures to the health facilities, and these are communicated to them depending on the available resource envelope for the whole on the macro side. Facilities make inputs in the budget process by presenting their shopping list, but after that, we agree on the priorities they have to implement within the financial year based on the resource variable. On the planning side, I would also score our facilities being the middle. Now, the management and including reallocation, there is some flexibility around the deployment of funds according to facility needs. There's also flexibility on the expenditure line items, but usually they have to first get authorization. Authority is sought before they change the work plans. If they have good justification, the facilities will be allowed to change the work plan and spend the money on an item that had not been envisaged in their work plan. And since there's that flexibility, I would also score them at middle. Now, on the expenditures, of course, salaries medicines are a bit centralized, but health facilities manage minor budgets for operational costs for public money. And with the RBF integration, we've seen some flexibility in even being able to buy some medical supplies if NMS or if the national medical stores have not supplied or they have run out. So that flexibility which we are seeing in the recent, I would score them on the high end. And remember, all our facilities have got bank accounts, which they operate independently, and there are 3 signatories on those bank accounts. The in charge, the sub-county accountant, but also a member of the health management unit from the community. So there's a lot of transparency, and we are impressed with the way they do it. Now, regarding the reporting, facilities are required to do financial reporting accountability based on the work plan's quarterly basis through IFMIS and manual reporting. But this is majorly financial reporting. So they do through IFMIS, but IFMIS, we don't have 100% coverage. So where they don't have it, they are doing the manual reporting. But our impression also comes into data management and reporting into our DHIS, which they do very well because it has implications on how they are scored and also the performance of a health facility in terms of service delivery. And I would also give them a middle class score. Now, this is the perspective I wanted to share, colleagues, this perspective of financial autonomy and institutionalization of the RBF at the country level. And this was picked from our field visits and responses and feedback from the health facilities. They are saying timely release of funds has been guaranteed, and it has led to more clients in the facilities. With RBF institutionalization, we have also seen improved service quality. They have also registered improved planning and budgeting. With the autonomy and of sending money directly, they have able to improve infrastructure and maintenance of the facilities, something that was not there before. They are also happy with the improved capacity of the health management committees in financial management, because there is a lot of training that goes on between every financial in order to improve their capacity, those who are new, but also the old ones, to refresh them on the financial management issues. There is also more timely referrals. Before this innovation, referrals were delaying and putting our patients to risk because, for example, they didn't have enough money or money as cash, fuel to transport a patient from one center to another. But now this one has been resolved. There's better reporting and data management. As I informed you earlier, all facilities are now reporting into our DHIS on a weekly basis. We have also seen strengthened financial planning and management at facility level from both Ministry of Finance and Ministry of Health. And the two other issues, as a conclusion, they are saying health facility in charges have learned and now understand how to plan and account for money, which was previously very weak. So next. Now, the enablers, of course, we teased out the ones which are very key, but colleagues, we cannot underestimate the issue of political interest. When the reform was put in place, we had a lot of haggling with the local governments because they thought they are going to relinquish control over resources. So political interest at both central and local government was very key to harmonize the implementation of this reform. Of course, I had said the government and donor support towards the decentralization reform was also very key, including the PFM reforms that supported flexible legal frameworks that support operational systems. The PFM as is, people still look at it as a setback to what they want to do. Interpretation, making it simpler, but also appreciating its role and also making sure it is flexible has also been a very good enabler. But more important also, ownership and alignment of our bottom-up planning and budgeting for local governments and rural facilities. Every financial year we sit with them and they are able to appreciate and also align their plans according to the government strategic plan and also appreciate the role of each other. So including the communities, we also noted that frequent trainings have strengthened the management committees and capabilities of the people at the grassroots level that are able to make sure that they account and make sure that the resources are used efficiently and effectively. Next. Now, these are the lessons we can share from Uganda. First and foremost, financial autonomy may not necessarily result into improved performance, because when we were implementing it at first 7 years ago, we thought everything was okay. But after 1 year, we realized there were so many challenges to do with service delivery. And therefore, even if any country goes that direction, don't expect results in the morning. There are some other things you have to move on. It is also critical that local governments in a decentralized setting are supported to develop PFM capacity. Most of the local governments did not understand the PFM. And those even who understood it, mostly even the DHOs, our own cadres in the district health officers, were opposing the reform itself. This includes the translation of overarching PFM law into operational systems. The third point I wanted to share with you is there is need to do periodic audits of the PFM processes to establish and resolve implementation bottlenecks that usually impinge on the public health facility autonomy, which should be part of the effort to address health facility autonomy. People misinterpret the PFM reform, but the moment you are able to identify where those processes are impinging on the services, those reforms should come in to amend the law. Now, lastly, as part from the legal and structural issues, public health financing, facility financing is actually influenced by a complex of interactions with multiple factors. As I said, there's need for sense making. People who could not make sense out of the financial autonomy we're proposing. Political interests at different levels can also bring issues and delay the implementation. Health facility capacity, the first thing to do is also to ensure that the capacity of the health facilities in terms of accountability and in terms of resource management is key. But as I also said, look at the bottlenecks that are envisaged in the PFM reforms from time to time. Thank you very much. Yes.
Thanks very much, Richard. The really interesting case from Uganda and already some questions bubbling up from the audience. So firstly, thanks to all of you who've submitted some questions into our Q&A and have also shared some thoughts and reflections in the chat, including some links to papers, etc., that will be a really rich resource for all of us on here. I'm now going to come back to some of the panelists with some of your questions. We're doing our best to bring these questions together and answer what we can here. You'll also see that some of them are being answered in real time in the chat. We will have about 20 minutes to do this, and then I'm going to invite our colleague Hélène to come in and do a bit of a summary of what we're hearing here today. So first, Sophie, I'd like to come back to you. There are several questions in the chat that sort of get at this question of what does financial autonomy really mean, especially at the PHC facility level? And does this include revenue raising? Should that be the focus, or should it really be on management of funds? Which of those funds are we talking about managing? If you could speak a little bit more about that, please.
Yeah, thank you very much. Yeah, I think a lot of the questions are very insightful. So I think just in terms of, so I think there definitely are tensions and trade-offs to be managed. And my personal take is that, some of the domains that were in that framework are more important than others. I think there are particularly revenue raising. There are a number of risks. There certainly are studies from places like China and Vietnam where you see that facilities that kind of maximize revenues, that causes all sorts of barriers for users, and then you have equity problems and financial access problems. So we have to think carefully about the kind of revenue raising side. But then there are other aspects which are, I think, a bit more crucial. And I think Danielle touched a little bit on those. But for example, if we think about the kind of operating costs at the local level, it really does impact on performance if you can't, you know, fix things, clean things, hire local staff to do small jobs that are really important. So it seems pretty obvious that that's an important area in most systems to give more autonomy without being too burdensome. I think there's some that are a little bit more complex. So the medicines and supplies area was highlighted by one of the questions. And indeed, you probably have more efficiencies of scale of central procurement. But at the same time, I think sometimes you just get local stockouts and so on. So having some flexibility to top up, I would say, is also pretty important. I think the staffing issue is really interesting. And I kind of reached out to, I think this is an area where we should be having more conversation with people. We all work in our silos, don't we? People who work on human resources, for example, people who work on health financing, they need to talk to each other about what's the optimal level of managing different payroll issues, because apart from anything else, it's one of your biggest costs, but it also links to performance, and it's such a key area. So kind of where that sits and where different kinds of staffing costs sit, I think is something we haven't quite ironed out. But I think the central management of salaries from a sort of civil service payroll really does make sense. And that's not an element that would necessarily work well at the primary care level. And then, as Danielle said, the big kind of capital costs also probably don't sit at that level. So yes, we do need to distinguish by different kinds of expenditures. For me, there is a kind of minimum set in a way of finance areas which I think we would want in most systems. So can you at least keep some of the funds that you generated on the revenue raising side? Can you at least influence your budgets that apply to your level? Not necessarily have complete control, but some influence. You know, are you able to sort of via across budget lines within reasonable limits? And are you able to address those kind of minimum routine operational costs without kind of prohibitive approvals and accounting? So to me, that's the kind of a minimum set that in most systems we'd want to see. But it is really interesting to kind of ask that question in a contextualized way. So if we look at Richard's presentation from Uganda, he's scored using our typology. He's done a very nice job of self-assessment, and he's given kind of medium to high, mostly medium, and I think one high grade, if you like. And he sort of talks about it as if they need to move to the high level. Actually, when you look at it, it looked to me as if it was quite well balanced for the Ugandan context. Maybe sitting in that middle group is actually where most of the primary care facilities in Uganda should be, and we don't necessarily want to give them higher levels. Higher levels also do carry some risks. So anyway, so I think that's also a question to Richard, just to reflect on whether, in fact, what he laid out was quite an appropriate set across the domains. I don't know if I missed any of your questions there, Cicely, because I just went off on a
Thanks
spiel,
so much, Sophia.
but tell me if I missed any.
That was great. Really thinking about distinguishing between the different kinds of expenditures. And I think many of us on the line will want to think through how we could use that typology and do the sort of self-assessment that Richard mentioned. But having some of these deeper conversations about what elements of different cost centers like HRH should and can be brought down to the facility level versus staying centralized. So Danielle, I'm going to come to you now. Several questions. First of all, if you'd like to reflect on the question we just posed to Sophie, but several questions also coming in, and I'll come to Richard on this as well, around capacity building and how do you strengthen leadership at the facilities? You spoke a little bit about some of the learnings that were coming out of at the dialogue this past August on what it takes to build some of this capacity. If you could maybe expand on that a little bit here. Thank you.
Sure. Thanks so much, Cicely. Yes, I mean, I really do think this is sort of the make or break of this reform success, like how capacitated these clinicians are and these managers are and the setups around them. And I also think that if a facility manager doesn't feel that they have the capacity to do this, they may be reluctant to actually increase their autonomy because they'll fear the punitive effects. If they don't know how to report and they don't know how to spend, they're also going to be a bit hamstrung. So I think the first thing is about sort of that thing of gradually increasing responsibility. So more carefully sequencing the costs under their control, being small amounts of money that they can kind of have a bit of a testing ground to work with. I think that's one way to slowly build capacity. I think the other thing I sort of touch on is ensuring that the PFM rules and systems that these facilities must use need to be simple and in line with their capacity. That was a big focus in Tanzania when the facility accounting reporting system was introduced. It was like given quite a lot of priority that the system and the associated technology was simple enough that facility staff, even including nurses, were able to use it. But even there, I mean, in some cases, it's still necessary to hire accountants to support facilities. And that's another point, is that these facilities don't need to be operating completely on islands alone. There are people that can assist. So if you have an accountant that can reach out to a group of facilities in their jurisdiction, leverage that capacity. If there's an accountant at a hospital that they can use, if it's the district health office. So I think it's about making sure that the system is all speaking to each other and everyone kind of knows that they can leverage capacity elsewhere. But yeah, I think these sort of mentorship and guiding programs that we've seen in countries like Ethiopia, Tanzania, where the Ministry of Finance and Ministry of Health are kind of coming together and going down to the local levels to train and give, sort of iterative and constant capacity building, not just one-off, because people leave and people forget. So I think it's, yeah, I mean, it's a multi-pronged approach that would be required, but I do think it really is key, and what you really don't want is to be crowding out clinicians from their core mandate of providing services.
Thanks for that, Danielle. So I think really the emphasis on this multi-pronged approach. So it's not just about building capacities of clinical staff at facility level, but also thinking across the system, where can you leverage capacities, for example, at the district level, to bring in those capacities that you'll need for that financial management. Richard, we're going to come to you now. There are many questions, as you can imagine, coming in, and several of them are really speak to the Uganda case. So I think there's some specific interest in understanding exactly who are the account holders at the health facility, which staff members, which clinical staff members are doing this work, and what capacities did they really need to build in order to successfully execute these functions. A second question is very interesting around what exactly was Uganda trying to solve for in increasing this autonomy? What was the initial problem that you were trying to address? And then maybe thirdly, I think reflecting as well on this question of capacity building. You spoke to this already in the presentation, some of the areas that have been key successes, what should be done. Could you help us understand a little more how, what has been the process for building the capacity that's needed, maybe both centrally and especially at the facility level? Thank you, over to you, and happy to come back to any of those.
Okay, thank you, Cecile. I think the first question about the account holders. At every facility, we have the in-charge. And this in-charge is a clinical officer at basically Health Center 3. Now, at Health Center 4, the in-charge is a doctor, and there are 3 members, signatories of this account. But the one who dispenses money, who makes requisitions before a check is signed, is the in-charge, who is the accounting officer. So the sub-county accountant, of course, by training is an accountant, and he's at the sub-county. He will sign a check, and another 1 member that from the community. And at the start of this reform, we were encouraging people to use people who have retired from public service, who have got good reputation, but who have also energy and and maybe worked in the health sector. But in some places, you couldn't easily identify this. But there are people who are in the communities with some level of education, and that's the sad. But this person is brought on board through a democratic process. It is the community that chooses him to be a signatory. So they have their work plan. the in-charge goes to the bank and withdraws the money, spends the money according to the work plan, and accounts for it before they go back to withdraw more money. So that's what question one was asking. Now, the question number two was about what problem were we trying to solve? Ideally, we are trying to solve a problem of poor service delivery at the health facilities, which was, which was as a result of delayed release of funds to the facilities. Funds come from Ministry of Finance to the districts, we're holding accounts, but from the district holding account to the facility itself could take not less than 1 month. Now imagine a facility taking 1 month without money for power, without money for water, without money to clean the premises, without money even to maintain the compound. And it was becoming unbearable. So that's why I went that direction. So right now the money goes direct to the facilities, and there is no question that we have seen an improvement into utilization, but also service delivery, because they are able to offer services at any time. Now, the capacity building question is a bit broad, but how did we do it in the first instance? One is to ensure that you explain. We took readers, Ministry of Health, to explain to our colleagues at Ministry of Finance, and this is the Accountant General's Office, that the PFM reform we are introducing needs to be understood by the implementing agencies. And these are the districts. And before we went to the districts, before we went to the health facilities, we started with the district health office and the chief administrative officers. So we made a joint effort to train, but the training was much in the way to handle resources, financial management, reporting, use of the different tools, but also appreciating the reform. Because in some cases we are facing a challenge, even our own people, the district health office, were not understanding why you want to remove money from their own control and take it down to where they don't have a say. So we had to bring in people, experts that could make them first understand and appreciate the reform. Then two, design courses, short-term courses. We took 1 year to train the districts and the facilities, but pulling them together into regional training centers. And at the end of the day, we also had to bring in people from Ministry of Public Service who could take them through the role of employees, their roles, their job description, but also things to do with mindset change. Because it was a reform, people had to don't think like the way we used to do things. This is a new thing. And we are not yet there 100%, but progressively we are seeing a positive trend towards achieving what we intended to do. Thank you.
Thanks very much, Richard, for those reflections. And I think you're also touching on some of the points that have been brought up in the chat, asking about whether we're really seeing, can we see this contribution, at least, on improvements in health outcomes. So thanks to Danielle and others who've provided some links to literature, though we know it's thin on this. But Richard, it sounds like you're noting that there have been improvements in this access to service delivery. And I understand that there is an impact evaluation underway in Uganda looking at this question. I think we have time. I'll come to the panelists maybe for one more question before we begin to summarize what we're hearing. And maybe first coming to you, Danielle, you spoke a bit about this exchange, and I'm curious if there were some common PFM requirements for granting facility autonomy, and whether this kind of came out, and whether these are really enablers or or issues that had to be dealt with. If you could speak a little bit to that, bottlenecks.
Thanks so much, Leslie. Yeah, so I think there are a lot of sort of bottlenecks that are more circumstantial than structural. So, I mean, there are definitely rules and systems that do provide that sort of structural impediment to direct financing. There are many more that can be sort of adjusted or relaxed if there's enough of a strong case made for why they need to be relaxed. But that does require health stakeholders to have a deep understanding of the PFM system so they can advocate for what needs to be changed and provide the reassurance that these challenges are not going to result, these changes are not going to result in leakages or inefficiencies. But yeah, this is going to very much depend from country to country, but there are some basic PFM requirements. For example, in most instances, to receive funding directly, facilities need to be designated as spending units or otherwise like a cost center under a spending unit. Having an approved budget doesn't necessarily mean you're a spending unit. In Mozambique, for example, district health services have a budget within the national budget, but they're not regarded as spending units, so they have to get expenditure authorization from district secretariats. And often the requirements to actually become a spending unit and have that legal status are quite burdensome and would prevent facilities from becoming spending units. So in Malawi, for example, facilities have to have a high-grade accounting officer with an accounting qualification. And that's, as we already heard, that's just not going to be feasible in most instances. So yeah, I think until there's like more significant flows of funds to facilities, these kind of requirements for being a cost center might need to be relaxed. And then, I mean, that also often comes in hand with being included in the chart of accounts, and that can also be quite difficult to adjust. So there may need to be more pragmatic solutions around that, about how facilities are included in the system without necessarily being immediately included in the chart of accounts. But that's where we want to be getting, because it allows for more transparency and visibility on what PHC facilities are receiving. And that also speaks to the broader issue that we're aware of, that PHC expenditure tracking is quite difficult. So that would contribute to that as well as a secondary benefit. And then, I mean, yeah, I'm very cognizant of time, but I mean, there's also things around facilities needing to have bank accounts in order to receive funds. And that's a requirement from the Ministry of Finance, but also just a practical requirement. And often the Ministry of Finance doesn't want to allow for that if they're going to be outside of the Treasury single account, which is the consolidated banking arrangements of government. And in rural areas, that banking infrastructure may just not be there. So, but again, this is not a structural impediment. This is something that can be adjusted. It has happened in certain countries where commercial bank accounts have been allowed to be used outside of the Treasury single account. It was happened in Benin, in Togo, and Uganda. Helene can probably touch on that. She's looked at quite a bit as well. But yeah, I mean, then that also needs to be accompanied by new oversight structures and audit capacity, because they are operating a little bit more outside of the system. But there are many more. I mean, there's also requirements often to set up sort of health facility management committees. And that's something we probably also could have touched on earlier with the building the financial management capacity of these entities. That it's not only the facility manager who is responsible for this. Most countries' facilities, especially those associated with the Bamako initiative, do have these committees that are responsible for overseeing the budget, voting it, and also making sure that they're carrying out some internal controls in some instances. So that's often also a requirement from the Ministry of Finance in order to disperse this money. But yeah, sorry, I think I probably should stop because of time, but we can come back to this at another stage.
Thanks so much, Danielle. Those are really helpful reflections. And we are going to wrap up the Q&A now with the panelists. And thank you so much for this. We're going to move to, and just to say, we will be capturing everything that's been shared here. So to those of you asking for the PowerPoint to be shared, the webinar will be shared, the recording, you'll even be able to access the questions. So do not fret, that's coming to you. I'd like to shift now, though, to my colleague Hélène, who will really help us kind of make sense of what we've heard here today. So, Hélène, if you're on video now, please, over to you.
Sure, thanks a lot, Sisley. Really amazing presentation and discussion today. I think a lot was covered, obviously. I won't be able to do a comprehensive summary, but I just wanted to pick up a few takeaway messages or key lessons, if you allow me, but I think would be relevant for both researchers or policymakers that I know are connected with us this afternoon. So the first one, really the first message that I think has really emerged quite quickly in the presentations, but also in the questions and the discussion, is that financial autonomy is clearly not a binary idea, a binary concept, right? We've seen that with Sophie. There are different degrees in financial autonomy. And the process for granting more financial autonomy, financial flexibility to PhD providers is gradual, is iterative. We've seen that with Richard. So different degrees, but also different components and dimensions, right? So we've seen that also with Danielle. PhD facilities may participate in budget planning definition process, but they can have also a much more restricted role in terms of how the resources are managed. So it's not black or white, it's not binary, it's not whether you have financial autonomy or not in a given context. So I think from that, the key lesson that I take is really that there is a need to unpack financial autonomy levels, but also components in a systematic way. This is really the role for the analysts and the researchers that are connected with us this afternoon. So really to do this assessment in a systematic way to understand where we are and where we want to go, right? And I think this is really a critical step to guide policymakers and really to inform future reform processes in this area. So that's the first thing. Financial autonomy is really complex. It's not black or white. It's not binary. We should really have a much more nuanced approach, and it should also invite us for more systematic assessment and analysis in countries. Second, I think it was also clearly emerging in the three presentations. Financial autonomy intersects a lot with both public financial management system, but also with decentralization reform processes, right? And I think this is really an important message for those of us who do work at the intersections between public financial management and health system and financing reforms. What we've seen with Richard, with Danielle as well, is that in some countries, financial autonomy contradicts or clashes with PFM and decentralization reform processes, right? We've been provided multiple examples. PhD providers are not necessarily recognized in the chart of accounts. They are not recognized or officially included as spending units, as government define or refine their chart of accounts. So that's one. There may also be issues with the idea of having a treasury single account, as facilities will need to have separate bank accounts, right, if they want to be able to access public funding. So that's another conflict or clash. Also, in some countries, the design of IFMIS systems, so the system to be able to report on expenditure, may not be appropriate. It may lack the granularity to be able to report on provider level spending, right? So this is really on the PFM side, examples on how financial autonomy may clash actually with the existing frameworks. On the decentralization side, what we've been hearing a little bit with Richard and with Sophie at the beginning is that in some countries, decentralization may also be associated with a re-centralization of powers. Re-centralization at the regional level, at district level, and so with that, facilities have less power, right? So I think it for me was really an important recognition from the discussion this afternoon, really acknowledging the conflict, the clashes, the misalignment between the idea of providing more financial autonomy and then the existing frameworks and rules and processes that are around the idea. So moving forward, what I do take from this observation is that I do think that from us working in the health sector, there is really a mandate to work much more closely with finance, budget authorities on one side, but also, obviously, also with subnational level authorities to make sure that as new reforms to modernize PFM systems, as decentralization processes are being accelerated, there is really a need to make sure that those reform streams do align better with the requirements for effective financial autonomy. Those reform processes are often disconnected, right? And I think we, working in the health sector, we have really this mandate of working with others to make sure that there is a closer coordination and consistency among and between those three different streams of reform. Danielle said it very clearly, we need PHC facilities to be recognized as spending units. They need to have bank accounts. They need to have flexibility in how they should use the resources, and they need a robust reporting system. So for those requirements to have effective financial autonomy, so for those requirements to be effective, we need much more aligned PFM systems and rules and much more consistent and aligned decentralization reform processes. So there's a broader agenda that I wanted to bring here, and I think the discussion made it very clear that those three streams of reform should be better aligned and coordinated. Cicely, if you allow me, the first takeaway message that I would like to take from this conversation, and I think this is an important message, I would say, for both countries, but also for partners. I think financial autonomy should not be perceived as an end in itself. I think it came very clearly in Sophie's presentation, but also in follow-up discussion. It seems to me that financial autonomy is really a tool. It's an approach, it's a means to better align resources with population needs, to enable PHC facilities then to address those priority needs, and thereby to improve access to quality services. So in my view, it's very important to reposition facility autonomy within this toolkit, within this broader toolkit. It's one component of a broader reform agenda to enable progress towards universal health coverage. I think this storyline should be clearly articulated, especially when we engage in the dialogue with finance authority. Obviously, financial autonomy is not the only component for health systems or health financing reforms towards universal health coverage, but it's really an important, if not a necessary component for UHC achievement or implementation. In relation to that, so for these means, for this tool, for this approach to be effective, I think Danielle said it, Richard also emphasized it, there is a need for capacity development. So I think this one is a very important message for countries and for partners. Greater financial autonomy requires support. It's not really a one-time provision, if you wish. It's really a shared responsibility across the different levels of the systems. It does also include the top level, right? The central level. It requires substantial capacity development. So financial autonomy doesn't stop with the introduction of the policy. That's really the point that I want to make. It requires support from all of us in countries at the different levels, but also potentially from partners who can support those processes. To close, last word, if the voice allows it, just a reflection, probably also reflection for future work or for future thinking in this area, in this space. I think I would like to recognize that maybe the consensus may not exist for or in favor of financial autonomy in many of the countries where you work. I've seen in some countries that some stakeholders, actually even within the health sector, I'm thinking of some medical doctors, some country district officers, they may see financial autonomy in a negative way. They may have negative perception about it. They may find it too risky. So I think we should not ignore that. It's something that I think we should very explicitly recognize. And so as part of the strategy, I would say, to implement successful reform in favor of financial autonomy, if this is really the goal in a country, I think we should really work on also aligning all those different political perceptions and interests, right? So really recognizing that there are broader political economic considerations around this idea, which is quite sensitive, around this concept of financial autonomy. So I think we should just recognize that very explicitly and work with that in conscious and be clear about the goal that we want all to achieve. I'll stop there. Thanks a lot.
Ellen, thanks so much for that summary. And thank you to all of our panelists and speakers today. It's been a really rich discussion with so many of you on the line with fantastic questions and sharing your perspectives, which have all been captured here. I just want to recognize that we're wrapping up here today, but there is a next webinar in this series on the 16th of December. It will be in French, and the focus is on legal tools to enhance health financing for UHC. So you will have seen a flyer there a moment ago for how to register, and we will, I believe, pop the registration link in the chat here, but if you're signed up for this webinar, you'll also receive the mailing around this. So do share with your colleagues and peers. This is all, again, recorded, and so are the previous webinars, which were also in French. So this is really a resource for everyone to use, and we really encourage you all to continue exchanging on this topic and within this community. So thanks so much again to all of you for participating today. Bye-bye.
Thank you. Bye-bye.
Bye, everyone.